Welcome, welcome back, clinical problem solvers. Rez Manesh here. So nice to see all your lovely faces on this beautiful Friday. Hope you're all doing really well. Robbie's going to be joining us in 10 minutes or so we can go ahead and get started. Does anyone have a case that they'd like to present today, where Robbie and I can try our best at dissecting it and sharing a few teaching points along the way? Here, I'll stay quiet until someone volunteers, and then we'll be able to dance together.
Hey, Maria, I'm back.
So nice to see you. Do you have a case? Yeah, right?
I do, yeah. I'm writing a case report right now. So it's kind of in CP Solver's format. I'll try and, merge it into that form.
That sounds wonderful. And Andrew, can you tell us a little bit about yourself?
Yeah, sure. So I'm a PGY1 in internal medicine at Yale right now. And I love running. I just got back from a run, ignore my somewhat crazy hair. Enjoying vacation right now. It's good to have some time off after a crazy beginning of the year. I'm in a perpetual state of getting back in shape right now. So I don't feel much like a runner these days, but we're trying.
Andrew, do you do long distance running, or what kind of running do you do?
Yeah, I used to do marathons in my clinical year.
Wow.
I was actually trying to qualify for Boston, and we were very close, but we didn't manage it. So one day again, probably in a post-residency life, I'm gonna work on that again.
Can you remind us, like, what pace do you have to keep per mile to qualify for the Boston Marathon?
So you basically need to do 7-minute miles before
Right.
your age, like 30 or 31, something like that. But what's crazy is so many young men are doing that now that you kind of need to run faster than that to even make it into the race, because
Wow.
it will like just bring the cutoff lower to make sure they don't bring too many people in. So it's pretty nuts.
Wow. Yeah, that seems really intense. Like my best mile was like 6 minutes on the dot, and that was in high school. So I don't think I could ever train to run the Boston Marathon. It seems like I've passed my peak, but hopefully you make it and you represent all of us, Andrew. Cool. So I'm glad first of all, thank you for joining us on your vacation week. And I'm really excited to get into this case. And we'll update Robbie once he arrives. But for now, I will do my best to try to discuss it. And we have Maria and Valeria, who are going to be scribing and doing the teaching points respectively. But do you want to take over the screen, Maria? And for the audience, remember, the best thing is to try to dissect the case as Andrew's presenting it, because you want to put yourself in the position of the solving clinician. And yeah, and that's the way you grow during these case simulations. So Andrew, whenever you're ready, please present the case and just pay attention to the scriber to make sure that they're keeping up with your case presentation.
Okay, I'll talk nice and slow for everybody.
Unlike your running pace.
Yeah, closer to my current running paces. Okay, so this is a 53-year-old man. He presented to the emergency department after a one-day history of dyspnea at rest and pleuritic left-sided chest pain. 1 week prior to admission, he had abrupt onset fevers, drenching night sweats, headache, productive cough, nasal congestion, sore throat, and myalgias prompting outpatient SARS-CoV-2 testing, which was initially negative. Of note, he completed a COVID-19 vaccine series that was Moderna 4 months prior to presentation. On review systems, he noted watery diarrhea occurring 4 times daily over the past week, and a sensation of feeling, quote, disoriented starting the day prior to presentation.
Wow, a juicy aliquot number one with a lot of information. And I think the key here is to focus on the findings that'll give you the greatest return of your cognitive investment. And what I mean by this, just to show you an example, you have watery diarrhea, you have headache, you have sore throat, you have myalgias. There's so many findings here. But really, what is the center of gravity of the case? The center of gravity of this case is inflammation. Fevers are probably the most specific finding of inflammation. And so the final finding has to be able to explain inflammation that's leading to the symptoms that the patient's presenting to your emergency department with. Now, in medicine, tempo is queen, and nothing is more important than tempo when it comes to diagnosis. And here, the one-day history is telling us that this is an acute tempo, right? So first, we got to understand the tempo, which will help frame the differential diagnosis. Hyperacute is instantaneous, like an aortic dissection. This isn't that. This is 1 day of symptoms. So we're dealing in the acute inflammatory process. Now the question is, once we say inflammation, once we say acute, we prioritize infection. Now we can use the patient's symptoms to try to localize the site of inflammation. But you can't give the same weight to pleuritic chest pain as you would to headache or diarrhea. Pleuritic chest pain is unique. Now, if this patient had no other symptoms and it was fever and headache, our focus would be the central nervous system, worried about a meningoencephalitis. But the problem, not the problem, the facts is that headache is so nonspecific and is usually a bystander. It's not the main player. So here, I think we frame it around acute inflammation and pleuritic chest pain, because that's going to give us the highest yield. And then as we go through the DDX for pleuritic chest pain, we see which one of these findings might also explain diarrhea, might also explain headache. There's something else I want to mention. What's so amazing about this case that Andrew's presenting is it's not only highlighting tempo, but it's also highlighting sequence of events, right? Because Andrew is telling us that this patient got a COVID vaccine 4 months prior to presentation. Now, that's an odd thing to volunteer. It only happens in the case simulation, as opposed to when you're actually interacting with the patient. But you understand that a vaccine will stimulate the immune system, and you might have sequela of overstimulation of the immune system. And you guys are all familiar, I think, at this point with the vaccine-induced thrombotic thrombocytopenia, VIT. The problem is this seems a little too long. There was a really nice article in New England Journal of Medicine where they have like a scoring system based on the D-dimer, the platelet-4 antibody, the timing to development of symptoms, and the clot and the thrombocytopenia. But 4 months just seems a little too much, but we'll just mention it there. Could this be a rare immune reaction? Possibly, but it wouldn't be my leading diagnosis. My leading hypothesis would just center on this pleuritic chest pain. So let's talk about pleuritic chest pain. What is pleuritic chest pain? I want everyone to take a breath in. This is, and not you, Maria, you're eating right now and you might aspirate, and then you might actually have true pleuritic chest pain, not a simulated form of pleuritic chest pain. But basically, when you take a deep breath in, this expands the lung. This expansion of the lungs will come in contact with the site of pathology that leads to pleuritic chest pain, which is basically taking a breath in and experiencing chest pain. And you can imagine that the lung can come in touch with the pleura, it can come in touch with the mediastina, it can come in touch with the intra-abdominal organs like the liver, the spleen. Right away, you have to apply base rate of disease for pleuritic chest pain, thinking of the most common etiologies. And I like to think of the P's, and there's so many P's, but pulmonary embolism, pericarditis, and pneumonia. these are pneumonia and pneumonitis. These are probably the 4 most common causes of pleuritic chest pain. But if you really wanted to challenge your mind, you could say at each anatomical level that the lung expands that causes pain can lead to pleuritic chest pain. So even aortic dissection, for example, can lead to pleuritic chest pain. You can have like a splenic pathology that when the lung expands and the diaphragm comes in contact with the spleen, causing pleuritic chest pain. And we already talked about the P's, pleuritis from any cause. Here's something unique. It's left-sided. So unlike SC segment depressions, which are non-specific and don't correlate with a specific coronary distribution, pleuritic chest pain actually does correlate with side pathology. So in this patient with the left-sided pleuritic chest pain of 1 day duration, I'm getting an EKG to evaluate for pericarditis. I'm going to ask, does it worsen when they're supine and does it get alleviated when they're upright? I'll listen on cardiac exam for possible friction rub. I'm interested in a chest x-ray right off the bat, just to see if there's pleural parenchymal pathology. And then I'm always thinking about pulmonary embolism. So if I don't find an obvious cause on x-ray or exam, then I'm saying, does the patient need a CT PE protocol to evaluate for clot? I'm actually not going to invest too much time in the drenching night sweat, sore throat, cough, myalgia. All of this could be like viral syndrome. So if you really wanted a plausible explanation, maybe some kind of virus with a bacterial superinfection leading to pleural pathology and making the patient feel crummy all over. That's probably base rate of disease, but I will pause there. Andrew, any questions for my thinking or thought process, or should we go on to the next aliquot?
No, that was beautiful. So for aliquot number 2, his further clinical history was significant only for a 35 pack year smoking history. He reported no recent sick contacts at home or work. He reported frequent work-related travel within the northeastern United States, where he designed cubicles for large commercial buildings. He would stay in hotels at that time. And he had been to several locations in Massachusetts the 2 weeks prior to symptoms. He was in New Hampshire when symptoms started. On arrival to the hospital, he was afebrile with a heart rate of 122, blood pressure of 152/84, a respiratory rate of 24, and an oxygen saturation of 89% on room air. He required 4 liters of supplemental oxygen via nasal cannula to maintain a saturation above 96%. He was profusely diaphoretic, speaking slowly due to shortness of breath and fatigue. He had rhonchi in the left posterior lung fields and agophony in the left lower lung fields. He exhibited diffuse muscle tenderness in the lower extremities, but without discrete lesions, edema, or erythema. And his neurological exam was normal.
Good morning. It's so great to see you all. I have to say a few things. The first thing is I'm a little jealous of you, to be honest, the rest of you, because I actually joined this meeting and I wasn't like in the headspace of discussing because I was a little late. And it really felt, I felt what it's like to be an audience member, to listen to the mesmeric Prof. Rez. It's such a treat. It is such a treat to bask in.
All the time I was speaking slow on purpose, just waiting for you to arrive, Robbie, to be honest. I was really dragging that first aliquot out.
That's hilarious. And second of all, Andrew, it's so great to see you. I can't tell you how awesome it is to see you surface beyond the craziness of intern year. If I hope I'm not mistaken, but I fondly remember your MS4 days, which were filled with VMR and other things. So it's really, really great to see you back. But it also makes me a little bit nervous because I imagine the number of cases you've seen as an intern is many, and choosing to present one of them is a little means we're in for a ride here today. So thank you for joining us. If you don't know, folks, Andrew has a Twitter handle and tweets out some incredible stuff that is very broad and diverse and all related to very high quality thinking that you should really check out. Maybe I can tackle the background data, and we got a lot of, like, it's very unusual that the background data is rich in the social history, which is very intriguing, and I'll let Prof. Rez weave his magic in the exam. And, you know, I'll tell you, I'm a little bit biased about, based on a recent M&M at UCSF, where we had a patient who had catastrophic APLS. And I say that not to invoke that specific diagnosis, but to make the broader point that if you look at all the P's that Reza outlined, it's hard not to prioritize the pleura as the P that's involved here because of the focality, jumping to the exam real quick. And that P, pleural involvement, may be in the form of an effusion, as Reza alluded to, or a pulmonary embolism is the most likely cause. And overlaid with the fevers that we have, it's tempting to start to search the social history for what kind of infectious process could be going on in this human being because they're a human being, but also in this human being because of where they've been. But the biggest caveat, going back to the APLS thing, is I'm learning that a lot of hematological hypercoagulable conditions are often triggered by infection. So I'm stepping back to say, hey, could this person have a subclinical propensity to have a PE that is triggered by an infection that causes pleuritis? So there's a big caveat that you have to put that aside for a moment, because there's a disconnect between when the symptoms started and when the pleuritic chest pain begins. But if we assume this is all under one condition, the travel to the Northeast is very evocative of a variety of infections that are common in that region, and those are essentially environmental organisms. Most of them are tick-borne infections, and some of them are mosquito-borne infections, with a small fraction of infections being acquired through the soil. But the question is, well, what tick-borne or arthropod infection can do this? And it really depends on the time of year. So that's an important filter to apply. But the vast majority of tick-borne infections spare the lungs. You'll find case reports of Babesia being so severe that it causes ARDS, but Babesia in the lung is relatively rare. The most common tick-borne disease that involves the lung is tularemia. And so here, while you wouldn't invoke that commonly, you might worry, hey, this is a person who's pretty sick and has pleuritic chest pain and has been in the Northeast. But short of that, the exposure beyond the Northeast to hotels, as was alluded to in the chat, is evocative of Legionnaire's disease. So that's something they'll have to think about, especially with the diarrhea. But before you think esoteric, you have to think practical. And I think the practicality on exam is this patient's pretty ill. So I'll pass Reza to reflect on what he glances from this exam.
I think that's brilliant, Robbie. Agree 100%. And they say the most ominous rhythm in medicine is tachycardia. And in this patient, most likely has sinus tachycardia as a compensatory mechanism for the underlying inflammation. And the highlights on this exam really comes down to the hypoxemia, tachypnea, and egophony, and the diffuse muscle tenderness. I think we can explain all of these respiratory problems with the parenchymal process plus minus a pleural process because of the patient's pleuritic chest pain. Egophony is when you tell the patient to say E, and then it becomes A, and that tells you that there's some fluid or pathology within the lung parenchyma. And so as Robbie mentioned, we were concerned for left-sided parenchymal pathology, and this exam confirms that. The question is there associated pleural pathology? And the best way to explain all of this is through a pneumonia that's in the left lower lobe that irritates the diaphragm when they take a breath in, causing pleuritic chest pain, explaining the egophony, explaining the hypoxemia, explaining the tachypnea. And then the question becomes, with pneumonia, this is where it gets unique. And I think this is where you can actually start prioritizing specific organisms, is really the muscle tenderness. And we'll talk about the muscle tenderness. I will say the speaking slowly is interesting, Robbie, because if you look at our altered mental status schema, one of the mimics of altered mental status is dysarthria. And so we'll track that. I'm not yet ready to say that the headache and the speaking slowly means that CNS is involved, though it's in the background. I think right now what's center stage is the lungs. And so the muscle tenderness is also unique because a lot of bacterial pneumonia, I don't recall the patients I've taken care of causing diffuse muscle tenderness, unlike viral pneumonias. there are some bacteria that can lead to muscle tenderness. And maybe I can just pass the mic to Robbie to reflect on that component. Because I think that, I don't know if you agree, Robbie, don't you think that's a little unique about this case?
You're being too kind. Take it home, my friend. I know you know it.
All right, so I know one specific organism, but I would love to hear, Robbie, if you have any other organisms in mind that are bacterial. Note that all viruses can do stuff like this, but the bacteria Legionella, one of the things we'll be looking for in labs is an elevated CK, and it often has an elevated AST because of some of the cell turnover, in addition to possible hepatic involvement. But that's one thing to consider here with just the muscle aches. If you're going to prioritize a bacteriology, you would prioritize Legionella pneumophila, which has, I think, 50 some strains. But any other bacteria, Robbie, that come to mind? Anything that's non-viral, pneumonia and muscle?
You know, half the reason why I handed you the ball back is I have had too much time to think about pneumonia recently. And so I didn't want to do this, but I'm going to do it now. I want to share something real quick. So here's a formulation of pneumonia. Yes, this is what I do with my spare time. Don't judge me. Most pneumonia is from oral flora that we swallow. Staph, strep. These are organisms that our body sees and is used to all the time. And they typically cause an isolated pulmonary syndrome, fever, cough, chest X-ray, infiltrate, unless your patient is immunocompromised, in which they can disseminate. So think about staph, strep, Klebsiella. It's usually, oh, I'm not feeling well, cough, chest X-ray, infiltrate, maybe some AKI, but that's it. Rarely you can get endovascular pneumonia from things like Lemire syndrome and endocarditis, but you can also get a whole slew of pneumonia from environmental organisms, from organisms that your body has never, ever, ever seen before. Now, why do I make that point? I make that point because of a dear friend who's here named Katarina, who basically prompted this deep dive reflection with a case of Q fever that she presented last week. And the list of environmental organisms is very long. As Reza said, all the viruses under the sun. We'll talk about the bacteria, many fungi, all of them really, and some parasites. But what's the bigger point? I don't want you to know the details here at all. The bigger point that Reza is getting at is exogenous causes of pneumonia. Basically, pneumonia that comes from the world tends to disseminate very quickly in the body. Viruses cause systemic symptoms with pulmonary features. These organisms all cause systemic symptoms with pulmonary features. Fungi are everywhere. They usually are respiratory dominant, but they're everywhere. Parasites tend to actually be a little bit more focal. So as soon as we pick up the theme that there is extra pulmonary manifestations of this presumed pneumonia in a presumed immunocompetent person, the overwhelming odds are that is an organism coming from outside, not staph, strep, the usual stuff. And yeah, with muscle tenderness specifically, I think the most robust associations I have are the two L's. Legionella, which is very common and given the hotel exposure, and leptospirosis, which Reza is actually a master of, with having published many a case about lepto, including lepto causing diffuse alveolar hemorrhage. All right, Andrew, back to you, my friend.
I love the three-step associations, and I'm glad you're all prompted with the recent pneumonia case. All right, let me figure out how to give this to you best, this next aliquot. So if I'm a little slow, I apologize. So a SARS-CoV-2 PCR was positive with a high cycle threshold of 41.6. For the BMP, he had a sodium of 123, potassium of 3.1, chloride 85, CO2 of 20. Glucose 110, BUN 35, which is high, creatinine of 1.47 with no baseline, but above the upper limit of normal, calcium of 8.3. The CBC, a white blood cell count of 17,300, hemoglobin 14.8, platelets of 354,000, differential 96% neutrophils, and I'll say 1% bands. He had a ALT of 140, which is high, AST of 354, ALK-Phos 60, T-Billy 0.7, albumin 2.4, high sensitivity CRP of greater than 300, dimer of 4.92, which is high. And I'll say the urinalysis demonstrated 3+ blood with microscopy showing only 6 to 10 red blood cells per high powered fields. And I know in real life you would have a chest x-ray. I'm going to withhold some of the rest of the initial workup for the sake of the discussion.
All right, y'all. As you all can see, Reza is on an important phone call that he to Scott. So I'll reflect here. And Andrew, I think you can teach us better than I can. I will say that this case is not definitively COVID because even though the PCR is positive, it actually took a long while for it to become positive. But Andrew, maybe I can pass the mic back to you since I hate hogging it and Reza's occupied. Can you teach us what you know about the cycle threshold and what that means?
Sure, I know the very basics. It's pretty much exactly what you just said. So, PCR runs off of cycling, like how many repetitions of replication does it take for something to be considered positive, like a virus, and testing the DNA or the RNA, I forget which. And yeah, basically the more times you have to run it in order for it to be considered positive, the higher the chance it is that that result is a false positive. It represents early infection, or it represents like late resolving infection as well. So there are a couple possibilities, and we didn't have that like cycle threshold result until after this case was over. But I'll just say that when I admitted this patient from the ED, I was told, you have a COVID patient. Good luck, treat this as COVID.
And the truth is, well, one, I step back and be like, that was a perfect explanation. Andrew, I would say that I think simplicity is the name of the game when it comes to education. Experts are experts and they know the details, but I think your explanation is one that will probably impact and permeate way more people than nuanced details about PCR testing. I think I'm just looking at the screen. It looks like folks didn't exactly catch the sodium. Do you mind saying that one more time, and then I'll jump into discussing?
It was 123. So it was
okay, perfect. Okay, so let's be real. In real life, when things are very busy, you see a patient who has in the middle of a pandemic who comes in with respiratory symptoms and has a positive PCR. You're probably going to presume it's COVID. And the truth is, you have to be very careful in general because you may get some further nuance, as we just did about the cycle threshold, to weaken that hypothesis. But there is a measurable, albeit low, rate of coincidental infection with COVID and something else. And this is a theme in medicine that you'll see all the time, where patient having one disease doesn't make them immune to another one. And the question is, what here is inconsistent with COVID? The first thing is the patient's immune status. So, breakthrough disease is real, but it's less common. Breakthrough disease with a high cycle threshold is even less common. And then the multiple features that we have here, a marked leukocytosis with neutrophilia is another ding against COVID. To acknowledge what goes with it is, of course, the mild hepatocellular injury. But I think the biggest ding against it is the amount of, is the UA. So let's break down the UA. You are seeing blood, but no blood. What does that mean? That means that there's a misnomer. So on the urinalysis or on the dipstick, when they say blood, what they mean is they're detecting a pigmented molecule. And those pigmental molecules are either hemoglobin or myoglobin. So hemoglobin can be further divided into free hemoglobin that's burst or hemoglobin within a red blood cell. So there are three things that cause blood on a UA: free hemoglobin, contained hemoglobin in the form of a full red blood cell, or myoglobin. And here we can rule out one of those two things definitively, which is that you only see a few RBCs, but 3+ blood. 3+ blood should have hundreds of RBCs, not just 6 or 10. So immediately you're wondering, is there free hemoglobin? And then you look at the serum hemoglobin and you're like, that's actually normal. So for somebody to have hemoglobin spill over into their urine, you're usually markedly anemic. So the case for myoglobin is high based on that and based on the finding of the muscle tenderness. So we have to restart to reframe this case, okay? And we have to reframe this case because this is not a respiratory predominant case. This is a multi-organ disease with respiratory manifestations. This is a multi-organ disease with respiratory manifestations. Uh-oh. Reza was spot on. And why am I actually jumping to a specific illness group now? You might forget to treat it. This case is not definitively Legionella, but this case is screaming empiric treatment for it. Depending on where you practice in this country or across the world, your antibiotic therapy may be very, very specific and tailored towards pyogenic organisms from the oral flora. You may forget azithro, quinolone, or even maybe doxy. Doxy has partial efficacy. So this is a systemic disease with respiratory manifestations, which takes us to the environmental organisms world. What should you do differently? You should test for Legionella for sure, but you definitely need to empirically treat it while staying humble. Because if Legionella showed up as classically as it did every single time, our job would be easier. And if infections didn't wear Legionella's coat all the time, our jobs would be easier. But it's very hard. So what would I do practically? I'd empirically treat for Legionella, and but I would stay broad. I wouldn't drop the anchor on it. And hopefully Andrew can give us more information to get some more progress.
Well, I do have more information and trying to keep a straight face here, not reveal anything. So just some other info before the final aliquots and the reveal. So the procalcitonin was 34, which is very high. The total creatine kinase was 6,343. And I do have a chest X-ray I can show you if you let me share the screen. Let me try and see if it'll let me. Not yet, but I have a chest X-ray I can show you all.
Maria, do you know who the host is? Is it Prof. Rez? Okay. I think he's like on a very, hey, Prof. Rez, if you can hear me, can you make Andrew oh.
There we go. Okay, let's see. You want to continue? Yes. Notes preview. It should be this. Let's try this. Oh, I need to go into my system settings. Hold on. This is I wanted the new MacBook Pros, so I'm
take your time. You know, it often feels way longer than it actually does when you're doing it. Like it's only been like 10 seconds.
So it is saying I need to close Zoom to show it. I feel like I need to show you all because it's really nice. Can I be right back? Is that okay?
Yeah.
All right. Give me 1 sec. I'll be back.
I had a sneaky feeling it actually would make him disappear, but that goes to show you that I'm an overly optimistic person. Let me do one quick thing actually. Kushal, oh, there he is. Oh, he's back. Okay. You back, Andrew?
Hey, I'm back. Okay, let's try it.
Let's do it.
Let's see.
I'm still, I think Reza has to make you.
Yeah. Keeping everybody on the edge of their seat here.
Hey, Prof. Rez, if you can hear me, Andrew had to leave, so can you make him co-host again? Alrighty, there you go.
All right, let's see. Okay, this is better. Here we go. All right, here it is.
Oy, oy. Wow. That's wow. Okay, you want to tell us what the read was?
Yeah, so the read was near complete left opacification of the left hemithorax with air bronchograms. That was the read with some sparing of like the superior lung fields.
Oh,
Very impressive.
indeed.
And
Shaw's
yeah,
really amazing. It's just basically not good.
yes, that's how I felt when I saw it.
Yeah, can you take us into real time? Like you're taking care of this patient. Where were you at this point? Like,
yeah, so when this patient hit the floor and I went through the whole workup, I looked at all of that. I met him and I was thinking, wow, this procalcitonin, there's probably some sort of bacterial situation going on given that chest x-ray being lobar. What I wasn't sure on was his muscle tenderness. When I was examining him for DVT, it was so profound. I was like, that's weird. This is probably like at least myalgia, maybe myositis. And I saw the AST and ALT. So I sent the CK, which is getting the CK I gave you. And yeah, I went to bed that night. I handed this patient off and I thought, oh, this person probably has some sort of like super infection we don't know about, but could be COVID myositis, which I looked up. Apparently it could be a thing because I know viruses like flu can cause myositis as well. So I went to bed, all of that, and then we got the final workup, which I'll give you in the next aliquot here, the final diagnosis.
Oh, I'm back, Robbie. Just a tag in, I was listening. That was an important phone call, but it was like an epic discussion. And really, I think one of the highlights for me was Robbie's frame of environmental organisms being more likely to disseminate. That's a pearl, as opposed to the oral flora that commonly results in pneumonia. I think these lab findings are so fascinating, Andrew, because you have this is all hindsight bias. We go look at the first aliquot and we're like, diarrhea, Legionella, hyponatremia, Legionella, AST elevation, or potentially hepatitis, and in addition to muscle turnover, Legionella, interstitial nephritis, Legionella. So everything is matching Legionella so strongly that this patient does warrant empiric treatment. And you just have to be very cautious with interpreting whatever study that Andrew sent. For example, the urinary Legionella test, it tests for the most common form of Legionella that accounts for 90% of it, but not all Legionella. And by the way, what's so interesting here is that just because the hotel is listed there, that's not what made us think of Legionella. All of us stay at hotels. So if I go to a hospital, I've been at a hotel 2 weeks ago, I hope that providers don't say, oh, it's Legionella. No, what made us think Legionella is a constellation of findings, and then everything started adding up. So you would send a urinary Legionella test, maybe the easiest if it comes back positive. If it comes back negative, the sputum culture is like very sensitive. I'm sorry, very specific, but not very sensitive, the sputum culture. And you can also send serology like IgM, IgG. But even if all those studies come back negative, the case is so strong that I would just say this is Legionella pneumonia, and I would treat accordingly. Leptospirosis, I saw coming up in the chat. Lepto can cause a multisystemic disease, but usually the center of gravity isn't the lungs, as this disease is. Usually they're in the extreme form of lepto known as Wills, there could be pulmonary in the form of diffuse alveolar hemorrhage. There could be liver in the form of hyperbilirubinemia. There could be interstitial nephritis, but I don't view it as primarily a pulmonary process. So Legionella, my friend, and I bet you the urine studies, urine sodium of 41 with the volume status being probably normal, is very suggestive of SIADH. You could send a serum uric acid to confirm that in the setting of pneumonia. And you have to be cautious with giving this patient fluid because you can just worsen the hyponatremia as the ADH is inappropriately activated. So bottom line, treat for Legionella, send the urine studies, send the sputum culture, consider serology, but I think you have enough data here to confirm the DX. It'd be really funny if it's not Legionella. Actually, it would be quite humbling, but I'm open to that. Robbie, anything to add?
No. Honestly, just to add, it's amazing what this community has done for me personally. I would actually be more excited if it were Legionella than it would be Legionella. Like 1 year ago, if this wasn't Legionella, I would go have a cry and be like, oh my God, I know nothing. But now, oh, the opportunity to learn. So
Robbie,
Andrew,
was that first RLR case you presented me, was it Legionella or was
Yes.
it was Legionella,
it
right?
was
Yeah.
Legionella, our first ever RLR ever. Episode number 3 for the CP Solvers was a case of Legionella that is actually very similar to this. Very, very.
And something unique I learned from you is that it's like a traveler's
Yes.
illness too.
Yep. Yeah. We're really, oh my God, we're in trouble if it's not Legionella. All right, Andrew, take the mic.
Yeah, so this wasn't a trick. The urine, when I got there the next morning, the ED did send the urine antigen testing, which was positive for the Legionella pneumophila serogroup 1, I believe is what it's called, pneumophila serogroup 1. So yes, you're absolutely right. I think the crux of this case, and I can talk about teaching points later, was when this patient was admitted from the ED, this was just COVID, like despite all of those labs and all of that. And they had empiric antibiotic coverage for community acquired pneumonia, but not for Legionella until we saw this patient the next morning. So really the discussion in the coming days, and we consulted ID since it was so interesting, was the COVID and the Legionella. And let me give you some more info for what happened later. So actually, they did send routine sputum cultures also. That ended up growing MRSA actually. And that was like 3+ MRSA, I believe. So it wasn't just a little bit. The initial MRSA screening swab was negative. We did send a sputum culture for Legionella for confirmation, which did eventually grow Legionella after about 2 weeks. The blood cultures were without growth. We sent an A1C just because he had the mild hyperglycemia. That was 7.1%. So in terms of predisposing factors, we found diabetes. And we did repeat SARS-CoV-2 PCR testing 1 week after he presented to the ED, and that was negative. So I can share some teaching points after you guys reflect on that, or I can just go for it now.
Oh, Andrew, quick question for you. As far as like management wise, did this patient get started on treatment for COVID? And did this patient also get started on treatment for MRSA pneumonia? Like, what did you guys do, man? I would love to hear the management aspect of it, like at time point 0.
Sure. So I actually have that right here. That's what we're talking about in the case report. So I'll just go ahead and I guess read through it now because that'll answer your question. So for the lobar pneumonia, he was initially started on empiric community-acquired pneumonia treatment with ceftriaxone and doxycycline. In line with our hospital's treatment guidelines for COVID-19, we initiated remdesivir and dexamethasone, given the oxygen saturation was 89% on room air. Baricitinib was also given for the high degree of CRP elevation and the supplemental oxygen requirement between 3 to 6 liters. That's again our protocol. He was continued on remdesivir for 5 days of therapy. However, we stopped dex and baricitinib after only 2 days of therapy after we identified the Legionella and the MRSA co-infections. So for the Legionella, he was ultimately treated with moxifloxacin for 10 days. For the Staph aureus pneumonia, he was initially started on cefazolin, given the negative MRSA swab, but we switched to Bactrim for a 7-day course once we had susceptibility results. So that was the antibiotic treatment. And in terms of like how we decided to go about doing this, so I'll just skip to this part here. So this case highlights the importance of considering bacterial superinfection in patients who present with a positive SARS-CoV-2 test. Although the rate of bacterial superinfection in COVID-19 is low, it's actually about like less than 4% per one study. The mortality rate is higher than in patients with influenza and superinfection, so that's notable. Recognizing bacterial superinfection is guided by findings similar to those traditionally used in the recognition of superinfection in influenza, like a rise in leukocyte counts, evidence of lobar consolidation, like in this case, necrotizing infection on chest X-ray, and recurrentive fever are what the IDS say to look for. And regarding the treatment, it raises the question of how to balance the treatment of patients with positive SARS-CoV-2 testing and confirmed bacterial co-infections. So while the DEX and other immunosuppressives like Bari have been shown to decrease mortality in severe COVID, these therapies can predispose patients to serious infection and predispose patients to worsening bacterial superinfection as well. So we weren't sure like how to balance, initially the positive COVID test and, these co-infections. So basically, without going through the rest of the paper, we said, you know, this was really more consistent with bacterial pneumonia, and especially since we had 2 confirmed bacterial co-infections, we felt we should treat this more so as a bacterial pneumonia and hold those immunosuppressants, because we were more concerned about complications from the pneumonias, the bacterial pneumonias, than the COVID testing. And then finally, regarding like the cycle threshold of the COVID test, what we said was with the negative repeat test 1 week after admission, we could say that was like late mild COVID, it was false positive, it was early, but basically we said it just wasn't the driver of what that patient, what brought him to the emergency department. It wasn't consistent.
Elusive search for the button. I can't wait to. You said that this was a case report, Andrew. Is that what you're saying? Is it out
Yeah,
yet?
we're working on it. Yeah, I should submit it in the next month. Yeah.
I think the amount of learning that you're taking from this case and disseminating through here and the case report is absolutely marvelous. And I don't honestly, I love that analysis of like, you're almost like saying whatever you think COVID might represent here, either a false positive or a delayed positive, you're being so practical about what it actually signifies, which is probably not acutely pertinent in this case. And I love how we infer that. You know, we infer that based on what the body is telling us. Because you're saying, hey, it's probably not COVID because the body reacted with a lobar infiltrate and a super high white count, and that you found other data. And I just find that so intriguing. So even if you see the bug there, you're saying the body normally doesn't react in this way to this bug, which I found really cool. Thank you for bringing this case to us. I think it's such a treat on a Friday to be able to go through the journey that we just went through. Before we pass the mic to Vale, I see Reza has unmuted himself, so I'll pass the mic to him.
Yes.
To close this out.
Thank you, Andrew, for such a lovely case and for all the excellent teaching points. One question I had for you. So we know that the MRSA nasal swab has a very high negative predictive value for MRSA pneumonia. I was curious, was there any literature to suggest that if you have SARS-CoV-2, it lowers the sensitivity of the nasal because there's like virus and other stuff within the nares?
That's something my co-author is actively researching right now, so I'll have to circle back and tag you all if we get a good answer for that. But we were going to talk about that in the discussion as well. That's pending because it is interesting. We weren't expecting that for sure.
Terrific. Thank you so much. Mike, to you, Vale, and Maria, thank you for scribing and like really highlighting everything that we needed to discuss before I even thought about discussing it in terms of red highlight.
Thank you, everyone. Andrew, this was an amazing case. Thank you so much for bringing it. And so we started with the chief concern and the history, which presented a case of inflammation characterized by fever. And so we remember always the mnemonic I made. And in this case, Reza mentioned the tempo is queen. And so in the patient, we had an acute onset of disease, and we should prioritize acute onset infectious, such as pneumonia. And then familiar with associated symptoms such as the dyspnea and the pleuritic chest pain. And in the case of the chest pain, we should prioritize the 3 Ps, the PE, the pneumonia, and the pneumothorax. Also, another Ps coming from other sources such as the heart, in pericarditis, or adjacent vessels, such as the aorta, and abdominal organs as well, such as in spleen irritation, pancreatitis, and esophagus etiology. And then familiar with a rich social history. The patient was from Northeast US, I think, and that's a region that is characterized by tick-borne diseases, but Ravi reminded us of a great pearl, that is that they rarely affect the lungs, and an exception would be tularemia. And then on the exam, we came with this, Andrew shared a really interesting sign, which is egophony, which is usually characteristic of consolidation. And it is an increased resonance of voice when auscultating the lungs. And in English, the word of choice to test egophony is 99, but in Spanish, we usually use 33, which is 33. And some people share in the chat that in French is the same, and in Hindi is ek, which is 1. Sorry, I'm not sure if that was Hindi or maybe another language from India. I know that you have a lot of languages. So then we talked about how strange was the muscle tenderness presenting on what seemed like a bacterial infection, because it is usually more characteristic of viral illnesses. And So we learned that some bacterial infections can be characterized by muscle tenderness, such as Legionella, which is actually because of the rhabdomyolysis caused by the disease. And so we will expect an elevated CK and AST, and also a great parallel is that myoglobinuria can be confused as hemoglobinuria in the urine dipstick because they take the same pigment, but we can differentiate because of the absence of red blood cells in the UA. And then also the urine antigen of Legionella covers only the serogroup 1, which is a great part of the species, but not all. So we should keep that in mind if we have a negative result, but a very like characteristic clinical presentation. And other bacterial infections that are characterized by muscle tenderness are leptospirosis, Escherichia staph, and tick-borne diseases. So thank you so much for this case, and hope to see you tomorrow.
Superb as always. See you all tomorrow.